Thank you very much, Peter, and thank you for those of you taking the time to come and share in this session. It is very short, so it means I'm going to have to rattle through my presentation quite quickly so we can get on to the next and then hopefully have time for one or two questions afterwards. So please apologies in advance if I don't cover everything that you'd expect me to in the short time. But I'm sure those of you who are GPs know this all too well, and those of you who are practice managers can see your GP sobbing in the corner of their practices over the last few months. And these are some of the reasons why GPs are unhappy and fed up with the current situation, particularly around the contracting position, the hugely increased workload that every practice is experiencing, including my own, and the sense that you're not able to perform in the way that you would want to perform, not providing the quality of service that you feel capable of and feel your patients deserve. And as a result of all of this, your income has certainly had a nosedive over the last few years and certainly will do this year as well. And on top of that, despite you working harder and harder, running around the hamster wheel ever quicker, the government, it appears, and the media certainly are constantly denigrating GPs and their practices and the services that we offer. And the fear is that despite it all, despite how bad it feels at the moment, there is worse yet to come. I hope that most of you are now fully aware of the contract changes. We're well into the process now, 3 months almost into the process, and so you should really be familiar with what I'm going to very quickly run through. But you should know that from next year, there will be a phase out of correction factor payments for GMS practices, and the review of PMS funding has just about started, and I'll come on to that in just a moment. All of the QOF indicators that NICE had recommended over the last couple of years have been implemented. Everything that was on the shelf has been taken off and dumped upon us, whether it was appropriate to do that or not. And one of the key things, which I'm sure we'll hear about in the following presentation, is the timeline for actually getting all of this work done has been compressed from 15 months to 12 months, which makes it doubly difficult to achieve QOF indicators. One of the real challenges, which will hit home next year rather than this year, is the upper thresholds which have been increased. There's a small number that have been increased this year. Next year, they all will be increased to match the upper quartile achievement. This means that QOF will become a mirage in the desert. As soon as you feel you've got to the indicator achievement level, it will move further away. So we will become our own worst enemies by working harder and harder. The QOF targets will get further and further away. The whole of the organisational QOF domain has been removed just at the time that CQC has come knocking on your door wanting evidence of being able to perform in the way that you expect to perform. And a subtle change, the contractor population index has been changed as well. That means that the size of your practice and the amount of resource that you get relative to the size of your practice has changed for your QOF payments. Now this year, that has been funded, but there's no guarantee that it will be next year. So as practices get bigger and the number of practices get smaller, if CPI doesn't change year on year, this will be a tax on QOF in future years, and you will see reductions in income over the following years if CPI doesn't increase and the resources backing it doesn't increase. A little bit of good news around immunisations, which again I'll come on to shortly, and there is significant extra work through the new DESs, which have been funded by the raid on QOF. GPs are absolutely fed up with the box ticking, and it seems now that Jeremy Hunt has had a Damascus revelation that he himself is saying that GPs are doing too much box ticking, and yet he was the very minister who has imposed all of this burden upon us. Most of the QOF indicators that were imposed are underpriced, so it means that if you are trying to achieve those indicators, you really need to scrutinise whether you're actually spending more money in terms of doing the work than you will actually get back if you hit all of the targets. The chasing the points at the QOF margins becomes much more costly as you start to get nearer the top of the tree. So you really do need to think about whether it is actually in your practice's interest anymore to really chase those final few points. And there's also in some areas requirements for additional training. the expectation that if your practice nurse has not got the necessary diabetic qualifications, now there is a requirement that she has, or he has, that necessary training to be able to do some of the QOF diabetic checks. It's the thin end of a micromanagement wedge. So whilst it might be diabetes this year, it might be another area next year. This all will have an impact on access. The more you're focusing on box ticking and chasing people to fulfill the requirements of QOF and DESers, the fewer appointments you've got left to offer to the patients who really need to be seen and haven't got a QOF indicator that makes them so attractive to be seen. And as practices work harder and harder, it does mean that there will be an impact on secondary care referrals, and the ability of patients to be seen in general practice, and therefore defaulting into secondary care. As I said earlier, many practices are very worried about the quality of service that they will be able to offer. Some of the indicators are just not workable in many settings, and we said so last year, and we were listened to last year, which is why some of the indicators stayed on the NICE shelf and weren't in our contract 12 months ago. But this year they've all been brought in. So if you've not got a service to refer people with COPD to for pulmonary rehabilitation, well, it's just too bad. The fact that not every area has got such a service is been ignored by the government, and they say, well, it will be commissioned at some point in the future. So you just have to suck it and see. There are also huge changes to the blood pressure targets. This is the big area that practices will be focusing on, large numbers of points, and it's much more difficult to achieve some of those standards as the target to achieve blood pressure has been reduced. The risk is that we try and push more and more patients to have more and more drugs, and the risk is that whilst their blood pressure may be lowered in the surgery, it might be much too low when they go home. They end up falling over, fracturing their leg, and going into hospital as a result. This is dangerous. We've told the government so, they ignored us, and the consequences could be the result that many people find themselves in adverse situations because of the polypharmacy that has been the result of driving indicators too near the bone. There's the repetitive and inappropriate questioning. I'm sure you've already got fed up of the GPAC questionnaire about exercise. This is asking little old ladies and gentlemen sort of who can't walk very far what their gardening skills are like, whether they can cycle sort of long distances and counting that as part of a questionnaire. It might be appropriate for some people to ask about their exercise and give advice and to do it once, possibly twice. But to do it every single year in the formulaic way that GPAC works is complete nonsense. Inevitably, there will be a rise in exception reporting. That should be a positive thing, a good thing, giving patients choice about whether they do or don't want interventions. The government, we know, and PCTs in the past, and CCGs and NHS England in the future, may well look at rising exception reporting as gaming the system. We need to challenge that, and we need to say exception reporting is a good thing. The key, though, is we want to get back to a time when we have more time to offer holistic care to our patients, not to go down this box-ticking route and having less time to really deal with patients' needs. Now, the DESers changed quite a lot from the plans that the government had originally, which were quite bad, to something which is not quite as bad as it could be. But nevertheless, this is extra work that practices will have to do. And you do need to think very carefully about whether you think it's appropriate to do it, whether it's cost-effective to do it. There are risks around some of these areas, not necessarily this year, but in future years. The online patient access DES for most practices now is fairly straightforward. It's about ensuring that patients can get online repeat prescriptions and online booking. The functionality is there in many practice systems and can be switched on and used relatively straightforwardly. The problem is potentially next year when the government's agenda for e-consultations starts to become much more aggressive and pushed and promoted. It may be appropriate for many patients, but for vulnerable patients, patients who are exploited in terms of domestic abuse or in various other situations, having access to your records electronically could be the worst thing possible. We need to find some safeguards before we really roll that out and promote it. We were really worried about the dementia DES because it was really portrayed as screening, and we know that there is no evidence for screening in dementia and can have a negative impact for those patients who start to worry that they may have dementia but don't actually have it, or certainly not in a diagnostic form yet. It has been modified, it is more appropriate now, but many practices still will have some concerns about, again, repeatedly every single year asking patients about their memory. Risk profiling is something that is really in the hands of CCGs, and in many CCGs I hope will work appropriately, but there is a risk that some CCGs might try to milk this for all that it's worth and impose additional extra work and burdens on practices. You are part of the CCG. You need to ensure that your CCG makes this particular DES work appropriately and do it in the way that sort of makes a difference to patients. Remote care monitoring is a tiny amount of money, but again, it's a potential wedge to what might come in future years. You're really just signing up to the principle in this year, but in future years it may require quite a significant amount of resource. In this year, the bureaucracy behind it may not necessarily be worth doing, but I think you need to look at that very carefully, and again, it depends what your priorities are within your CCG as whether it'll be workable for you or not. And then there's also the uncertainty about lesers. They are, in many cases, vulnerable to AQP bids. Many of them are now in the hands of the local authority, have been rolled forward this year, and so should, for the large part, be okay for this year. But in future years, there are real risks that these are vulnerable to AQP. There's the huge standard contracts that have to be completed to be able to just maintain sort of the lesers or to be successful in retaining them in the future. So as local authority budgets are squeezed, it's quite possible that these areas become squeezed as well, and resources for lesers become much less available. Some slightly better news: we've managed to negotiate some genuine new money for a whole raft of new vaccinations. It is extra work for practices. The resource is there to a limited extent to be able to support some of this activity. So rotavirus for young children, shingles has just been announced about the catch-up for 79-year-olds and a programme from 70. A seasonal flu will be added to the normal annual seasonal flu campaign, but it will be for 2 and possibly 3-year-olds, which will start from this year, and will be a nasal spray for young children. And then the MMR Capture, which practices should already be embarking on, and which provides a limited resource for those patients who are outside of the additional services component of Global Sum. So only a small amount of resource for those extra patients that you're providing that service to. But the impact for practices, if you just did what you did last year, you'd be losing about £31,000. That's for the average practice. So you need to be going around the hamster wheel that bit faster to try and retain some of this resource. And that's before you factor in the impact for the PMS and correction factor changes. This is the big issue that many practices will face, not this year, but from next year. The redistribution of funding, the government is committed that over a 7-year period from 2014, all practices over that 7-year period will work towards a standard capitation payment. That means for higher funded PMS practices, and certainly those practices with a very big correction factor, they could lose considerable amounts of resource. You do need to remember that the global sum value will increase during that time, so you aren't going down to the global sum value that practices have got now. It will be, over a long period of time, increased, assuming the resource flows within the same pot, and there is no copper bottom guarantee yet that that will be the case. Not only have the government left practices feeling extremely victimised and fed up, but they've also had a good go at locums too. So the shift of responsibility for employer superannuation has been moved from PCTs, as would have been NHS England, onto practices. And the limited resource that's there has been played out to every single practice, although it's still being worked out about how it might be made available to some PMS practices. But certainly the commitment is there to do that. But it does mean that those practices, particularly smaller practices who use a lot of locums, will end up picking up a bigger bill as a result of this change. And it is unfair that those practices who don't use any locums have suddenly got a very small amount of resource that they didn't really need. To add insult to injury, there's just been a recent announcement that the payments for locum appraisal has been cut as well. So locums are really under the cosh at the moment. And then there's all this added woe for many other GPs as well. We're in a commissioning conference. For many, that might be a good thing. For some GPs, it's still a threat and a worry. And a whole list of other concerns that they have, which sadly we don't have time to dwell on at the moment. So what might practices actually do? Well, firstly, you need to protect your patients. Stop chasing targets just because they're there. Put the patient first. Think about the risk of chasing targets and also the cost of doing so. You need to prioritize your practice. Do important QOF areas sort of within 9 months and consider whether you can afford to do some of those external activities that you've previously done for free any longer. You need to develop your practice. Think about the additional work that you can potentially deliver using the skills that you've got, working with others, perhaps in groups, perhaps in federations, maybe in larger practices. And think about how you can protect your GPs and how you can maybe plan for the future. So we've got increased workload, we've got decreased income, impact on quality, increased stress and burnout. So it's time to think much more business-like, and it's time to protect patients, protect GPs, and protect your practices. Thank you very much.
Yeah, that's me. Ladies and gentlemen, good morning, and welcome to the first ever conference that's taking place in the departure lounge at Heathrow. The last time I saw curtains like this, I didn't see my grandmother again, actually. First of all, can I say, that don't bother writing things down, because everything that I'm going to say here now in this next few minutes is actually going to be there. So if you want to just make a note of that, you'll be able to pick everything up. I've got a problem straight away. With this whole business. I don't have a handle on exactly how the changes are going to impact on our practice. We're working our way through it at a local level, anticipating the June exit of payment, which is hopefully going to balance everything out QOF-wise. I'm sure practice managers understand what I'm saying there. Identifying new routes of income that popped up on our exit of payment. I had 4 payments at the end of May, 2 of which came in the first week of June. Last equivalent period last year, I had 2 payments, so one of them at the moment is unaccounted for as well. So we've got a difficulty, I think, in terms of understanding exactly what it is we're mitigating against. So all I've got really for you are some common sense ideas, which I want to share with you. First of all, don't commit to anything that will cost you hard cash. This is going to be controversial. GPs and PMs will probably like it, but I'm a practice manager. I have to deal with my own backyard. I can't deal with fixing the entire NHS. We have to be realistic. We're in a place where everyone has to work harder for the same or less. There's no point in whinging about it. We leave that to the great and the good at the top of the profession. We've got to deal with it. Apart from MPs, of course, they seem to be fairly well off. But there's a massive difference between those income earners that require no additional cash outgoings and those that do. Take the DES, for example, that requires us, in our instance, to get 150 patients up and running on the website prescription appointment booking system. Now, that's a good case in point. There's a fair amount of administration going to be needed. Forms to be printed. The reception staff have to push them to patients to get them on board. Then the forms have to be processed. And then the link to your database system set up. But the time it takes will have to be absorbed, folks, so that the practice gets a net income, which is the absolute value of the DES. I mean, if you're really saying that you can't do it, then don't do it. Take a long, hard look at the relationship between any additional service you might provide and the revenue it provides and the cash cost of providing it. Not happening. Back. Not happening. Nope, not happening. Okay, sorry about that. it's not working. Top tip, minimise your costs. Top tip number 2. Again, this is about time. Minimising your costs is about time. Get rid of your soft feelings towards your current suppliers and get quotes for everything. Couch rolls, flu vaccines, ink cartridges. Join the LMC buying group. There was a message I got day before, from the Forum of Practice Management saying they've set up a buying group. Just hunt for it on the web. Get an email group together of all your local stationery companies, medical supply companies, electricians, builders, and send a BCC email to all of them asking for a quote for your PAT testing, for your window repairs, for your new examination couch, for your new ophthalmoscope. You've got to work at it to get those costs down. Persuade the partners that they will have a positive impact on their income in the medium and longer term if they cut down on the use of locums, whose cost has skyrocketed by anything between 15 and 17% this year by virtue of the fact that we've been stuffed with the pension costs. Thank you very much indeed. Superannuation payments now our responsibility. More time in surgery perhaps, but a good return on the investment when it comes to the partners' drawings. And we've just come up with a fantastic idea. Take your own non-clinical rubbish to the tip, as we aren't being funded the cost in Lancashire of that anymore. That's going to save us about 480 quid a year. Next, maximise your assets. This is the area where we go to where, you know, the politicians and the great and good don't like talking about this. But come down hard on DNAs and time wasters. In the real world we inhabit, as opposed to the one occupied by the politicians and the health lobby organisations and so on, we know just how much DNAs cost us in wasted time and appointments. It's all well and good doing the DES, opening up more appointments times for patients. What good is it when they don't turn up for the damned appointments? Review your room usage. Make sure that the building or rooms you occupy are utilised for the maximum amount of time in a working week. Can you provide a home for a commissioned service on a regular weekly or monthly basis? Counselling, physiotherapy, partner healthy lifestyle organisations. Do you need to check your agreement with your CCG to make sure there are no restrictive rules on the use of your building? Get close to the health service providers and the decision makers in your local authority and keep in the loop as to what the Director of Public Health and the associated council committees and local politicians are pushing for. Any willing provider. Can you provide such a service at your surgery? Make sure your website's fit for purpose, that patients can get straight to the information that is most important to them, and that you promote your key services, clinics, and the DESs and LESs that you may well be working on. They are ultimately for patients' benefit. 4, maximise your income. Check again. My grandfather was a carpenter and his key phrase was, measure 3 times, cut once. Check and check again. Has every service been claimed for in the month? Have you claimed all the expenses that you are due? Review your rates upwards for extra work outside the contract every 12 months. Why not? Everybody else does it. Make sure that all medical report requests are accompanied by a cheque for the cost of providing it. No practice manager should be having to run round getting people to pay them for medical reports. Register for the DESs before the end of June. They all make sense. If you don't make the cut by the end of March next year, it's not a disaster. If you do, it's much needed income. Consider doing medicals for adoption services, immigration services, for HGV licences, for Her Majesty's Prison, for all the businesses on the massive industrial estate that's probably just a few minutes from your practice. Consider fitting IUCDs for other practices at your practice. Consider your options for becoming a training practice. Small practices are not excluded from this valuable activity, and we've derived enormous benefit at our practice from having students on board. Notional rent. Don't let the review go through on the nod. Challenge it if you're unhappy. GP premises are subject to the same price and market forces as other commercial properties, and rents and prices are starting to recover. Do you want me to shut up, or am I still okay? Okay. GPs, review your staff costs. GPs spend an awful lot of money on their staff. And even though I'm a turkey voting for Christmas, Grab the bull by the horns and review it. Organisations always increase staff costs in times of plenty. Look at Gordon Brown and Tony Blair and the Health Service. And then find the opposite situation difficult to handle. Can you comfortably manage reception with 3.5 staff rather than 4? If you don't want the cost of redundancy or are reluctant to have that terrible conversation with a colleague, and I understand because I've done an awful lot of that in my own career, what about waiting for natural wastage to kick in and staff members to move on and make your changes then? Can your staff do more for you in a given time period? Is it possible to devote an hour here or there to summarising on a regular basis without compromising front desk cover? If you don't check, you could be missing an opportunity. Get everyone on side. Everyone in the practice needs to be singing from the same hymn sheet. Communicate with your colleagues, please. Tell them about QOF changes, the need to be more productive, the need to watch our costs. Go easy on the paper towels, of course. A 10-minute staff briefing, face-to-face, every couple of weeks, even if it's split in a bigger practice, isn't a crippling commitment, but will have a marked impact on your colleagues. And if you communicate via your intranet, fine, no problem. What I'm saying is communicate. And finally, we're under severe pressure. I mean, we've heard that from Richard. It's very sobering. But I would suggest that you let it wash over you a little bit. Our first and most important duty is to our patients, always. And we are more than capable of coming up with innovative solutions to the financial challenges that we face while guaranteeing great care and treatment. Ladies and gentlemen, don't undersell yourselves. Despite the unhelpful hysteria leading up to April the 1st, I haven't noticed any downgrading or diminution of the service that we offer to the patients that come through our doors since then. And if you're being realistic, have you? I'd like to wish you good luck for the future, but luck, I'm afraid, does not come into it. It's just going to be hard graft, and it's no pain, and it's no gain. Thank you very much.
Thanks very much indeed. Because we're under real-time pressures here today, I'm actually going to run straight into the next talk, but Richard and Mark are going to be around at the end of that talk. If you have any burning questions, can you hang on to them for half an hour, please? Because I now want to introduce, end of slideshow, we've got another one hopefully going to load up.